the primary care crisis and how to solve it. So this is going to be Tom's talk today. We're looking forward to it. Thank you for being here. It's great to see lots of friends and new faces in the crowd. It's great to see so many people interested in primary care at UCSF. We have a community here, and it's nice to see that with every year there are more folks that are interested and involved. We're going to have a reception after Tom's talk out front near the Nobel Wall, so we'd love to talk more with you and get to know everybody in the crew. And there's lots of food, there's good drinks, so stick around if you can. We'll have a little bit more of a discussion afterwards. Without further ado, a couple words of introduction for Tom himself. Tom is a mentor to many of us and very influential in healthcare policy. But the introduction that he asked me to give you was a little bit more humble, which fits his personality. It was just this, that Tom was a full-time primary care doc in the Mission District in San Francisco for 32 years. So he has street cred, he's been in it, he knows what it's like, and has a lot of thoughts about how to fix it. He's now a faculty member in the Department of Family and Community Medicine over at San Francisco General Hospital. So without further ado, that's what
So, if anyone's way, way, way up there, come on down. Come on down.
Welcome.
And anyone who wants to leave, even if you're in the front row, just go ahead and leave. It's okay. It's fine. So, how many of you are med students? And how many are residents or docs? Are there any nurses, nurse practitioners, PAs? Pharmacists, pharmacy students? Okay, so a lot of med students, seems like. So first I want to say something about the title of this talk, because it probably freaked you out. The answer is no and yes. And most of the time I'm going to be explaining what I mean by that. So if we look at the projections that a number of people have made, first we have demand, which is what the population's needs are for primary care. And that demand is increasing for various reasons. What are some of those reasons? Anyone? Why is the demand increasing?
Old people.
People like me, getting older. Okay. And a lot more people getting older because of the baby boom. And what about any epidemics going on that might influence demand for care? You know what epidemics are happening.
The obesity epidemic.
Diabetes, obesity, huge. And then there's one more thing which will be different in different places, which is the influence of the Affordable Care Act, which in some places like California will probably increase demand quite a bit. In other places like Texas probably won't increase demand at all. So demand's increasing for primary care. But what about the supply to meet that demand? So who makes up that supply? Well, we'll talk about that in a minute, but let's just talk about docs. And the people who, and the other thing is I want to say is pediatrics is sort of different from adult primary care. Most people feel like there's not a major shortage of general pediatricians. Now you can debate that, but everyone agrees that there's a major shortage of adult primary care physicians. And who are adult primary care physicians? They're general internists and they're family doctors. So the supply of general internists and family doctors is projected to go down. Now, there's one thing that people who did these projections, so one person projected a shortage of 40,000 primary care physicians by 2020, and then a more recent projection was 52,000 by 2025. But they left out one thing. which can really influence these projections. And that thing is primary care progress. So if primary care progress is able to greatly help to increase the percentage of US medical students who go into adult primary care fields, this shortage won't be nearly as bad as these projections suggest. But even if primary care progress does an amazing job and manages to reduce these shortages by a half, that's still a big shortage left. So we need that work to increase the number of adult primary care physicians coming out of US medical students. It's critically important work. But it's probably not going to be enough to solve the whole thing. So if you look at the residency match of 2013, about 3% of US medical students chose general internal medicine, and about 6% chose family medicine. That's a total of about 9% of US medical school graduates going into adult primary care. That's really nowhere near enough. And that has not changed for the last 3 years. But it looks fairly likely that UCSF will have a significant jump in 2014. That's what we're hoping. How about nurse practitioners and PAs? We were just talking about docs, but primary care can be primary care clinicians. We use the word clinician to include doctors, nurse practitioners, and physician assistants, who can pretty much do most of what primary care needs. If you look at the projections for nurse practitioners and PAs, about 2/3 of nurse practitioners go into primary care. So that's really enormous help. About 1/3 of PAs go into primary care. But if you look at the projections based on how many graduates are expected from those disciplines, and you add PAs, nurse practitioners, family docs, and general internists, it still looks like the ratio of primary care clinicians to population is going to go down by 9% between 2005 and 2020. So what that means is, again, nurse practitioners and PAs certainly help, but not enough to solve the problem. Is everyone sort of okay with that kind of large macro system sort of projection of the workforce? So we need more, but we're probably not going to get enough more. Now we get to this issue of panel size. What's a panel, besides those things on the ceiling there? Can anyone say what a panel is? I'm a doc. I have a panel of patients. What is my panel of patients?
All the patients you care for.
Yeah. It's the patients who, consider me as their doctor, and I consider them as their doctor, as my patient, or as the patient that I'm responsible for. I shouldn't say my patient, because they're not my patient. They are themselves. So these panels, no one knows exactly how big the average panel size is in the United States. Some people have suggested 2,300. Kaiser, it's kind of around 2,000. Most community health centers, because the patients are more complex and more psychosocial problems, there's more language issues that take a lot of time for interpretation. Their average panel sizes are more like 1,200 to 1,400. But let's just assume panel size is somewhere between 2,000 and 2,500 in general in the United States. If you look at how long it takes for a primary care physician without any team, without any help, to do really good preventive care, it's been calculated that it would take about 7.4 hours every single day to do perfect preventive care, to do everything that the U.S. Preventive Services Task Force recommends that we do. Anyone surprised? 7.4 hours a day? Just for prevention. No treatment. Now, if you look at chronic care, it's an additional 10.6 hours a day. So if it takes 16 hours a day, 18 hours a day to do chronic and preventive care, leaving 6 hours for acute care and care coordination and lunch and maybe a nap or two. It's not doable. With the panel sizes we have, we really can't take care of patients and have any kind of reasonable work-life satisfaction. So having these large panels means, number one, poor access for patients, because the more patients you have, the more demand you have. If you don't have enough time to meet that demand, people have to wait to get care. Quality is inconsistent because you're too rushed to do a good job for everyone. Building relationships with patients is difficult. Burnout is a huge issue. So burnout. Burnout is not, well, my job's really hard and, I need a break for a while. Burnout is like, I want to quit and never come back. That's burnout. So if you look at this survey that was done recently of general internists and family physicians, 27% said they were burning out, and 30% said, I want to get out of here in 2 years. Now, of course, most of them didn't get out of here in 2 years because they needed to make an income. But burnout is a huge problem. And if your panel size is really big, the bigger your panel size is, the more burnout there is, because you're just working. You can't keep up. It's also not good for patients because you're not treating people in a good way. So here's the problem. Now, after this, we're going to have some very hopeful, wonderful, enthusiasm-creating things that we're going to talk about. So far, what I've been saying would probably lead most of you to pick radiology. So we're going to change that. And I think what is really important to keep in mind is that not only do we need all of you to be primary care physicians, primary care clinicians, primary care nurses, so forth, we need you to be leaders. Because leaders is what's needed to change the situation of poor access, quality inconsistent, burnout so that you don't really want to be there. We need leaders to change that. And that's what the rest of this discussion is going to be. So don't think of yourselves as that poor, plodding family doc who's seeing 15 patients in the morning and 15 patients in the afternoon, gets home at 10 o'clock at night, and then gets on your computer to do all your email. That's not what you're going to be. If that's what you're going to be, it's not going to work. There are ways and there are examples of practices where that's not the way it works. And those are the practices that we need all of you to create and to lead. So the dilemma is panel sizes are already too big, but we can't reduce the panel size because the shortages are getting greater. So that means panel size will get bigger rather than smaller. Larger panels means poor access and more burnout, unless we think completely differently. So that's what we need to do, is think differently. So let's go back to those projections. So plan A, that's always the better plan, right? You always want to do plan A if you can. Plan A is to try as hard as we can to increase the production of primary care clinicians, doctors, nurse practitioners, and PAs. That's what we'd really like to do. That's what primary care progress is trying to do. Thank goodness. So plan A is what we'd really like. But it's not going to be enough to solve the shortage. I don't think there are very many people who think that from 9% of U.S. medical students going into to primary care, adult primary care, we're going to go to 50 or 60%, which is what we need. That's just a jump that would be hard to imagine. So again, we'd love to solve the problem with more clinicians, but we need a plan B in case we won't succeed, which we won't. Doesn't mean we shouldn't keep trying. So plan A is more what we call macro system. It's dealing with the whole workforce of the country. Plan B thinks more about microsystem, and microsystem is what happens within each practice. And what happens within each practice can enormously change this demand capacity problem that we have. And so what Plan B is to say people who are not clinicians, and by non-clinicians we're talking about RNs, pharmacists, health educators, health coaches, panel managers, medical assistants, front desk receptionists, all of the people who are not what we call clinicians. Now, some RNs will say, we're clinicians. We're just using the word clinician in a certain way. We'll be talking about RNs and their enormous capacity to add capacity to our system in a few minutes. So the people in the practice who are not MDs, NPs, or PAs, we need to change what they do, because they could help solve this demand capacity gap. And we need them to do it. So the first thing is, if you ask people, well, what's the problem with primary care? People will say it's a physician shortage. And then, of course, the solution is more physicians. And we've already said that's not going to work. It'll help, but it won't solve it. Some people will say, well, it's a clinician shortage. We don't have enough MDs, NPs, and PAs. I think what we've already shown, that's true, and that's not going to work either. So we really need to redefine what this shortage is. Because if you define it as, say, a physician shortage, then your solution is going to be more physicians and you're going to fail. The way I would like to define it is a demand capacity gap. So if demand is people needing care, and if capacity is our ability to provide that care, I think what we've said very clearly, there is a gap between the demand and the capacity. That's what that first chart showed. So we can address this gap either by increasing capacity or reducing demand, or both. And the point I'm going to try to make is that we can do that without necessarily having a lot more doctors, nurse practitioners, or PAs. Now at the practice level, you can actually measure demand and capacity. So at the national level, but also at the practice level. So at the practice level, does anyone have any idea what's the capacity? Let's just assume that all care is done on a one-to-one physician visits, which hopefully in the future will do care by phone, by email, by group visits, by nurse visits, by pharmacy visits, by health coach visits, and so forth. But let's make it real simple. Let's say that the only way to get care is a one-on-one physician visit. What is the capacity of a practice to provide that care? Well, it's the number of physicians. It's how many days they work each year. It's how many patients they see each day. So if a physician works 200 days a year, sees 20 patients a day, their capacity is to see 4,000 patients that year. Does that make sense? Now, of course, it's much more complicated than that, but just to think about it in a simplified way. So that's their capacities, 4,000. Say your panel size is 2,000 patients. We're just talking about one poor, sad primary care doc working all by him or herself. So, capacity of 4,000 visits a year, or demand 4,000 visits a year. Capacity is one doc. Excuse me. That's the 4,000 is the capacity. What's the demand? So say the panel size is 2,000, and each patient comes an average of 3 times a year. That's 6,000 visits. Patients want 6,000 visits. What's available is 4,000 visits. we have a huge demand capacity gap in that practice. And most practices indeed have such a demand capacity gap. They have more people wanting appointments than there are appointments to give. And what that means is that access goes down. The only way to have really good access for people to be able to get care the day that they want the care is for demand capacity to be the same. So what you could do is you could say, well, rather than work 200 days a year, what about working 300 days a year? Just some weekends and maybe an occasional 1-week vacation. If you work 300 days a year, then your capacity and demand will be in sync. They'll both be 6,000. But more likely they'll be 0 because the doc will leave. So you really can't solve this problem by making docs work harder, or NPs or PAs, because already we have this enormous problem of burnout, and you're not going to solve the problem of the demand capacity gap by increasing burnout, because people will just say no. They'll just leave. So it has to be a different way to solve the problem. So here we have a different curve. Remember that red curve, which is the capacity curve, went down in our previous graph, which just looked at doctors? Well, how about, what if the demand curve went up? And the demand for care and the capacity for care equaled each other. The way to do that is what we call share the care. Changing who does what in the practice. Having other people in the practice who are not clinicians add capacity to see patients. That's what we're going to talk about the whole rest of the time. And that's what the practices that you work in are going to be doing. So we visited a whole bunch of what we call high-performing practices. Now, high-performing, we did not measure all the things the practices do to prove that they're very high-performing. A lot of these practices are practices that are kind of well known around the country as being like really good practices that patients like, that have good clinical data, where people have good access. So we kind of talked to a lot of people like, what are a bunch of really good practices? And several of us visited these different practices. And from these practices, and these are the kind of practices that, number one, you'd love to work in, and number two, you will create when you are a primary care leader. Or you'll take a practice that's not like this and you'll make it like this, or you'll start one that's like this. So these high-performing practices have certain characteristics. And we call those characteristics the building blocks of high-performing primary care. And it's pretty interesting. Some of these practices were in big organizations like Group Health or Kaiser. Some of the practices were in the VA. Some of the practices were smaller private practices. Some were community clinics. They all looked kind of similar, which is very interesting. What it made us think is, there is a good way to do primary care that really works well, where the people who work there like working there, the patients like it, the clinical outcomes are good, people can get care quickly, there's good continuity of care so that patients are seeing their own provider most of the time. So there's certain characteristics which we call the 10 building blocks of high-performing primary care. So these building blocks are like a description of good practices, but it can also become a model for other practices to become high-performing. So we use these building blocks as the model. Now we're not going to talk about all the building blocks, but the point I wanted to make about these high-performing practices is, if some practices can do this and equalize demand and capacity without burning out their physicians, if some people can do it, we can all do it. So let's go back to the issue of how do we add capacity without burning out our docs, nurse practitioners, and PAs. So this is what we could call the wedge approach to primary care capacity. Part of capacity, which is our ability to see more patients, part of it is the NPs, PAs, and MDs. Part of it is what we call non-clinician licensed personnel. Part of it is non-licensed personnel. Part of it's patients, and part of it's technology. We're going to go through these different ones. These are the ways that we consider that we can really increase capacity without more clinicians. So the non-clinician licensed personnel are RNs, pharmacists, physical therapists, behaviorists, and there are others too. But they're people who have a license to practice in their particular professional capacity. Non-licensed personnel, and most of them so far, are medical assistants. So medical assistants are usually high school graduates, often young, often minority people who go to school for 6 months or maybe 9 months, don't learn a huge amount, but really are really the glue that hold a lot of practice together. And medical assistants are in every single primary care practice in the United States. So they can add capacity too, we'll talk about that. Patients themselves can both add capacity and reduce demand. Remember, there are two ways to reduce the demand-capacity gap. One is to increase your capacity, the other is to reduce your demand. We need to do both. And finally, technology can help with all of these things. So let's talk about the licensed personnel. Let's start with RNs. It's very interesting, RNs. RNs tend to be used to work in hospitals and in home care and in public health. But there's not really an RN primary care track. Like, how do you be a really great primary care RN? So a lot of RNs in primary care kind of come from somewhere else. There's a lot of great research that shows that RNs could do a lot of things that doctors can do, and actually can do them better. They just need to be trained, and they have to have the authority and the time to do it. So RNs are an enormous resource to increase capacity, to see more patients. So if you look at respiratory infections, RNs can provide care equal in quality with MDs, with higher patient satisfaction. Women whose history indicates uncomplicated urinary tract infection can be treated by RNs without clinician involvement with high quality. For uncomplicated low back pain, RNs can independently manage patients as well as physicians with higher patient satisfaction. So here's 3 very common primary care conditions that you don't need a doctor, a nurse practitioner, or a PA to take care of. RNs can take care of all of those things. Imagine if RNs took care of all of those things. Maybe that's, I don't know, 15% of all primary care. That would increase primary care capacity by 15%. RNs are an enormously underused part of primary care practices. RNs can perform pap smears of equal quality to those done by physicians. All of these things, RNs could be an enormous help to reduce the demand capacity gap. Physical therapists, very interesting what physical therapists could do. Studies show they can manage low back pain with better functional relief and better patient satisfaction compared with physicians. Pharmacists, another enormous untapped group of professionals. Pharmacists can manage hypertension, including doing all the medication adjustments, better than usual care. At 18 months, 72% blood pressure control for pharmacists versus 15% in the usual care group, which was taken care of by docs. If you look at Kaiser, for example, Kaiser just recently published a study that showed that in Northern California Kaiser, 80.4% of patients with hypertension have their blood pressure controlled. 80% compared with 50% nationally. A lot of that is done by pharmacists, not by doctors. It's not that doctors can't do it, it's just that there's often not time for doctors to deal with blood pressure plus the 4 or 5 other things they need to deal with in the visit. This was a RCT of patients with diabetes and elevated blood pressure. Patients with RN management, including doing the medication changes under standing orders, were 3 times more likely to reach the blood pressure goal in these patients with diabetes and hypertension. So again, physical therapists, pharmacists, nurses, enormously increased capacity. behaviorists. Increasingly, there are behaviorists now in primary care, whether they be licensed clinical social workers or all of this is kind of, I don't want to say it's routine, but you know it's algorithmic. There are rules for how people need preventive care, and you can teach almost anybody to follow those rules. So panel managers who could be medical assistants can really do all this preventive care. How many hours did it take for a lone physician with a panel of 2,500 patients to do preventive care? 7.4 hours a day. What if someone else did all that? Or even did half of it? Just think of how much more capacity you could create. So again, you need standing orders. There are a number of studies, and there are new ones coming out almost all the time, showing that if you have a medical assistant panel manager who can look at your list of patients and your computerized list that shows who's overdue for which of those preventive care services, make sure they get done, that if you do that with someone else, you don't rely on the physician who doesn't have enough time to do it, you can increase the percent of people who have all their preventive services taken care of. So the quality improves. So for example, how might mammograms work? The medical assistant checks the registry every month to see who in the panel of patients is overdue for a mammogram. Sends the mammogram order to the patients. The result comes to the medical assistant. If it's normal, the medical assistant notifies the patient that it's normal. If it's abnormal, the MA notifies the clinician and an appointment is made. For most patients, clinician is not involved at all. Now for women who are 40 to 50, where it's more a patient choice whether they want to get a mammogram or not, then the clinicians would be involved for a discussion. MAs can do the same thing for especially colon cancer screening and can make sure that cervical cancer screening gets done. And of course the pap smears can be done by an RN rather than the doc. So preventive services can be done a lot by medical assistants. If you have enough medical assistants, if you get paid for that work, if they're trained, and if there's standing orders that empower them to do it. Now we like this whole team structure in which a medical assistant works closely with the same clinician all the time. And what that allows to happen is that the medical assistant and the clinician really share that panel of patients. So the patients know both the clinician and the medical assistant. The medical assistant knows the patients, and the medical assistant's always working with the same clinician, so they know how to work together. What happens if you have these stable teamlets is that clinician satisfaction goes up. So this was some survey work that we did in some of the San Francisco Department of Public Health clinics. If you have stable teamlets where the same MAs working with the same clinician, the clinicians are more satisfied. And if the clinicians don't have a team at all and they work with different people all the time, they're a lot less satisfied. So it can help with physician burnout. But the other thing it can help with is the doing the preventive care. So if you have a medical assistant, and over here it looks like at immunizations, and the dark blue column is clinician confidence that medical assistants will do a good job doing all this preventive care. And in the blue column, there's a stable teamlet where the clinicians working with the same MA. And the column over to the right is there's no team at all. And clinician confidence that the MA is going to do a good job is really much lower if they don't sort of work with the same MA all the time. And the same thing with cancer screening and with diabetes care. So having these stable teamlets helps to engage the medical assistants to do a good job, and that the docs have confidence that the MA will actually do that work well. This is a picture of a high-performing teamlet. And this is another one. So teamlets are good. Now, remember we talked about everyone in our panel needs preventive care? Well, quite a few people in the panel, but not everybody, needs chronic care for not super complex things, like they might have arthritis, or they might have diabetes, or they might have hypertension and hyperlipidemia. They don't have like 7 or 8 different diagnoses, but they do have 1 or 2 or 3 chronic illnesses. For those patients, health coaching can be an enormous help. And health coaching really is making sure that people understand their disease, understand how to control their disease, learn some very simple behavior change techniques, really understand their medications, and work with them on medication adherence. Because a lot of people who are poorly controlled with diabetes, hypertension, cholesterol are poorly controlled because they don't take their meds. And they don't take their meds because no one's really explained to them their disease, what happens if the disease is in poor control, and they don't feel like there's any reason to take the meds. So for example, in diabetes, the coaches that we've trained teach people what is hemoglobin A1C, which is the average of your blood sugars for the last 3 months. What is it? What's your number? My hemoglobin A1C is 10. What's your goal? Your goal is 7. Most people don't know their number and don't know their goal. There's a really nice study that shows that if people know their number and know their goal, just those things, people do better. So teaching them their number, teaching them their goal, and this is also true for blood pressure and for cholesterol. Then how do you get from your number to your goal? Which is often like eating better, more exercise, and taking your meds. And the coaches work with them on all of those things. And we're finally beginning to get some really good data that with health coaching, working with patients on all of these issues, the outcomes are better. Also, the coaching is what takes the most time. It's very easy to write a prescription for someone's high blood pressure meds, to explain to people what is high blood pressure, what's your number, what's your goal, what will happen to you if you don't reach your goal, and what are the different ways you can reach your goal, and how do these medications help you reach the goal and prevent the complications. All that stuff takes a lot of time. That's what health coaches can do. So the study that we're almost finished doing, that Dave Thom, who's here today, has been working on for the last 2 or 3 years, we found that if you take a composite measure, which is hemoglobin A1C below 8, systolic blood pressure at goal, and or LDL at goal, that people who had worked with health coaches, patients, low-income patients who worked with health coaches, had a much greater chance of meeting those composite measures, those good outcomes, than people who had usual care just from physicians. So health coaches can really help. They can both do a lot of the work that physicians don't have time to do as well, and can actually help patients get better. So health coaching is a way that non-licensed personnel can improve care and add capacity to see more patients.
Quick question. So, Tom, if the data isn't quite ready yet, it's fine. But I was just curious if the individual measures were also higher. So rather than the composite measure, which was really higher.
Dave, you can help us.
Yeah. First of all, we chose a composite measure of reaching 1 or more of the goals for which the condition they were enrolled as being out of control.
Yeah.
That was because we wanted to graduate at one clinic if we could, and would get enough people with one condition at that clinic. But we did also the secondary analyses order each one separately. For diabetes, it was strongly significant. I don't remember the exact numbers, Rachel, right? For lipids, it was borderline significant between 0.05 and 0.10. Though when we broke it down further, it was significant at one clinic, the main clinic we worked at. We had a clinic that didn't do nearly as well with horse variety disease. And for blood pressure, nothing. For whatever reason, we didn't sort of figure that out. The blood pressure didn't respond either in the peer coach, which was designed to test hemoglobin A1C control, but we don't have that simply. So we're still testing the blood pressure. But for hemoglobin A1C, big, politically important, and just make a difference. And for LDL, a little less, but still pretty good.
Great. Thank you.
So health coaching really can make a difference. And again, this is health coaching this is not by nurses, by pharmacists, by doctors. This is health coaching by medical assistants who are well trained. But these are people with not a lot of medical background, but they can learn to do this kind of health coaching. And the other thing is that they tend to be a lot more like the patients that they're taking care of. So most of those patients were Latina or African American, and the health coaches were all these young working class Latina women, and the patients really related to them. So let's just take an example, high blood pressure, a different way to take care of high blood pressure. You look at your registry of people with high blood pressure. If blood pressure is not controlled, someone contacts the patient who's not the doctor, probably a medical assistant. They might get health coaching if that's what they need. If they need medication intensification, the pharmacist or the RN can do it under standing orders. And the clinician's barely involved, and the blood pressures get better. That's where we all like to be. If we don't do this, if we just do primary care every day, we won't survive. We have to do some of this too. I just came back from doing this. That's why I feel good today. So what else can medical assistants do? They can be scribes. Now, scribe is kind of a yucky word. I'd like to change it. But that's what they're being called. So there are places where the medical assistant is in the visit with the clinician, sits at the computer, at the electronic medical record, and does all of the documentation. So here's these two pictures were taken like about 1 second apart. So they're in the same room. The doc's doing a physical exam and is calling out what he's finding. And the MA is writing it in the computer. Then the doc says, I'd like to order such and such labs. And MA orders it in the computer. Such and such x-rays, such and such medication changes. By the time the visit's over, all the documentation's done. Doc goes home 2 hours earlier, happier, patients like it. It works really, really well. So MAs as scribes is beginning to very slowly become a way to add capacity, because the reason that this was at the University of Utah Health System, the reason they could do this and have a lot more MAs per clinician was that the clinicians could see 2 or 3 extra patients a day. Also, the documentation was so good they could bill higher code level. So they made more money with less time, and that paid for all the extra MAs. So there was a business case for doing this. Lisa?
Patient satisfaction survey at the end, because the doctor's actually looking at the patient, which we don't do when we're at the computer the whole time.
Yeah. Patient satisfaction went way up. You're absolutely right. A lot of patients are unhappy with their doc sitting and talking to the computer. So we pretty much talked about this. Scribes can increase capacity and reduce burnout both. This is this whole problem with the electronic medical record. It pushes more work to clinicians, which we really have to figure out ways to have less work done by clinicians, work that you don't need a medical degree to do. So Clem McDonald is a doc who pretty much invented the first electronic medical record in Indianapolis at the Reagan Street Institute. So Clem says, if changes are not made to reduce these time penalties on primary care physicians for all this documentation, there will be no more primary care physicians left to penalize. So this is like one of the inventors of the EMR saying, EMR pretty much has been sucking in terms of primary care physicians. We need to change it. So I don't know how many of you have ever used eClinicalWorks and the jelly beans. So this is a patient that says, I come in to see my doctor for an examination, but it seems all he wants to examine is the computer. This doctor says, I used to be a doctor, now I'm a typist. This patient says, I really like my doc of over 10 years, but rarely get to talk with her face to face. As I'm talking, she's typing and annoys the hell out of me. So scribes can deal with some of this. Here's the doc talking to the computer. Patient sitting there says, hey doc, I'm here too. So again, the EMR is a great advance. We have to have EMRs, but there's got to be ways to to reduce the amount of time that it takes to document and to improve the patient-doctor relationship as opposed to, and the patient and the doctor-computer relationship. So Scribes is one way to do that. Now to do all these things, to add capacity with these non-clinicians, you really need you need more of them. So there are a number of places in the country that have staffing ratios of like 2 or 3 non-clinicians to every clinician. And that's what we really need. A 1-to-1 ratio, you can't do all of these things. Now I'm kind of looking at the time because I'd like to just finish up fairly quickly. Will patients accept care provided by non-clinician team members? What we know is that patients want to know their team. And one of the things is that we don't think it's right for a patient who trusts their doc to ask the patient to trust a team of 8 people. That's just too much to ask. Patients really want their team to know them. So that's why the teamlets, in a way, is more helpful, because we're asking the people to transfer their trust in the doc to trust in a smaller team of people. We don't really have good evidence to show that that works, but we would like to get that evidence. And someday Dave will probably get it for us. Blue Shield of California Federation did a phone household survey and published in 2012, which is kind of interesting. 81% of Californians surveyed said they're willing to receive care from a team, even if it means seeing their physician less. So there's some evidence that show that patients will accept this very dramatic change in how primary care is delivered. Just quickly, patients can be trained to be health coaches, just like medical assistants can be trained to be health coaches. And we did a study of low-income patients with diabetes being trained to be peer health coaches. There are several studies, including ours, that show that low-income patients can improve care significantly for patients with diabetes compared with usual care. And here, this was our group of peer health coaches that is being trained. They were trained for about 36 hours on health coaching, diabetes, hypertension, and cholesterol. Now remember, we talked about we need to increase capacity and we need to reduce demand. Reduce demand really means self-care. And there's been an increase in self-care. You know, we now have home pregnancy kits, we have home HIV testing, we have the internet, which is a plus and minus. There are more over-the-counter medications. We do know that people who have home blood pressure monitors, who self-titrate their medications, can achieve better blood pressure control than that achieved by doctors alone. So patients can be very key to improving their blood pressure. We know that patients on anticoagulation who home monitor and self-titrate their warfarin doses can achieve better control than by MDs. So patients can do a lot of these things if they're trained to do them, which can reduce demand, which helps the demand capacity gap. So again, sharing the care with other people in the practice, that increases capacity. Patient self-care reduces demand. Technology can really, really help with all of these things. So remember we talked about panel managers, looking at the group of patients, the registry, and seeing who's overdue for mammograms, who's overdue for hemoglobin A1C tests, who needs colorectal cancer screening. You actually don't need a person to do that. A computer can do it. So a computer can very easily tell who's overdue for different preventive care things, can send to the patients what they need to go do these things. Now, people are needed when the patients don't respond. But a lot of this panel management, preventive services can be done by computers. You can program computers to do med refills. They can say, okay, this patient with diabetes, they're in good control, and they've been in the clinic in the last 3 months, so therefore they can get a 6-month refill of the same meds. If they're in good control, but they haven't been to the clinic for a year, then you could say, okay, we're going to give the patient 1 month and ask them to make an appointment. If they're in poor control, we'll give them a month refill and ask them to make an appointment. So a computer can do that as well as anyone else. Interesting study shows that actually patients, remember we talked about nurses can take care of people with uncomplicated urinary tract infections? so can patients. They can do self-treatment, including with antibiotics, and it's safe and effective. So again, with technology and self-care, we can reduce demand. You could imagine you have this kiosk hooked to a vending machine. Patients enter their urinary tract infection symptoms into the kiosk. If there are no red flags like fever or multiple previous infections and so forth, 3 days of antibiotics could be dispensed from the vending machine with no involvement of healthcare personnel whatsoever. Everyone thinks this is crazy. I don't think it's crazy. You could do the same with strep throats. Okay, what have we said? The primary care physician shortage needs to be rethought as a demand capacity gap. You can increase capacity by sharing the care with non-clinicians. How patients will respond needs further research. We also don't know exactly how much capacity we're going to add and how much clinician burnout we can reduce. Those are things that we need to find out. But we're pretty sure we can do those things. Patients can help as peer coaches. Demand can be reduced through growth of self-care, and technology can facilitate all of this. What this means is that primary care is not the primary care of today. This is the primary care that you all will be experiencing and will be creating. This is the job for the UCSF primary care doc of the future, to create practices that reduce demand and increase capacity in all of these ways, and that you're going to be the leaders of all of this stuff, which is really fascinating and challenging. So again, since Plan A, more primary care clinicians, is not going to succeed sufficiently, and even though primary care progress will help, we have to implement Plan B at the same time to try to change our practices so that we can deal with the demand capacity gap and also with clinician burnout and making primary care more fun. So thank you.